والصلاة والسلام على أشرف الأنبياء والمرسلين وعلى آله وأصحابه أجمعين. Emeritus Professor Tan Sri Zulkifli Abdul Razak, Rector of International Islamic University Malaysia, our distinguished speaker, Associate Professor Dr. Mohamad Haniki Nik Mohamed from Kuliah of Pharmacy IIUM, members of the University Management Committee, our moderator for today, Tuan Haji Murshid Kassim, Dean of Center for Foundation Studies IIUM Gambang, organizer for Murabbi Talk Series, Associate Professor Dr. Lihana Borhan, Director Office of Knowledge for Change and Advancement, Deans and Directors, brothers and sisters, Assalamu alaikum warahmatullahi wabarakatuh. I, Iman Jamil, a third-year student from Kuliah of Engineering, am honored to be an MC for today. Murabbi in Action Talk Series is a platform for our IIM community to share their effort and experience in implementing Sejahtera Academic Framework. I welcome all of you to this current episode of the series featuring Associate Professor Dr. Mohamad Haniki Nik Mohamed from Kuliah of Pharmacy on the topic of tackling the collision of tobacco epidemic with COVID-19 pandemic. Let us begin our session with the recitation of Surah Al-Fatiha. Ameen, Ameen, Ya Rabbil Alameen. Now it is my pleasure to have the Rector of IIUM, Emeritus Professor Tan Sri Zulkifli Abdul Razak, to give his welcoming remarks. Please welcome.
Thank you very much, Iman. Bismillahirrahmanirrahim. Alhamdulillah Rabbil Alamin. Wassalatu wassalamu syafil anbiya mursalin. Sayyidina Muhammadin wa ala alihi wa sahbihi al-ba'in. La hawla wa la quwwata illa billah. Associate Professor Mohamad Haniki, Brother Murshid, Professor Shukran, Associate Professor Liana, Amelia, Rusnani, whoever else behind the screen, brothers and sisters, thank you very much. It's always a pleasure for me to give a small welcoming address for this, because this Murabbi in Action is really an actionable sort of activity that we begin not only to introduce personalities, but also work that has been done that we could learn from. And particularly today, it resonates very well with me as far as Haniki is concerned, and particularly in the question of tobacco. It went a long way back in USM when we were fighting tobacco when everybody else was not doing very much. In a poison center that we had all around the world, people do not take tobacco as part of poisoning, except in USM, because we thought that tobacco and nicotine in particular is poisonous enough to kill you. So we took this action, and it was almost a difficult task to do because we are bucking the trend, as it were. But Alhamdulillah, over a period of time, we are able to put USM, the Poison Center, and in a global sense, because we were funded by Rockefeller for the work that we are doing, a clearinghouse, and all this. I think perhaps Haniki will tell us. But my point exactly is we need to be very firm over what we believe, and this is what I think the word Murabbi is all about for us. It is about keeping to your principles, keeping to ethics, and fighting even the greatest giant on earth. Yeah, I tell you this because when we were doing it, my travel all the time when there is a tobacco meeting, I have a lot of problems. My bags are always being displaced somewhere. When there is a tobacco conference, yeah, I will never check in my bags anymore. I have to carry it myself, because when I arrive, the bags is not there. I don't know what happens to it, but it cannot be a coincidence each time you travel on a tobacco meeting, your bags gets missing. So after a while, I learned that I bring my own luggage in the cabin, so that I'll get me away from this sort of distraction. But that's not the end. At the end of the day, I've got a phone calls from these people, which says that, while we fight this, I remember the statement that still sticks in my head. They kata, you have overstepped your bounds, and you have thugs to deal with people like you. I mean, that's a kind of experience that we've got when we fight big giants like big tobacco, big pharma, and all these big commercial houses that thinks about nothing but profits and not even the human welfare. And I think this is a kind of fight that we need to take on. And I hope Murabbi would mean this. Murabbi would mean that you are on the front line, you take action and you fight them, even to the extent that sometimes your life is put on a kind of a, on a kind of threat one way or another. But alhamdulillah, I think if you do it well, Allah subhanahu wa ta'ala will always protect you. And I'm happy to say that tobacco, to a certain extent, is already made well aware among Muslims, and I think that the underlying thing is that when the Western people are well educated for tobacco and they don't know where else to sell the tobacco, they dump in the third world, they dump it in the Muslim world, because they need to still make the profits, they need to still have the numbers, and therefore they sell it to us who are not aware of this issue. So when you talk about COVID-19, when you talk about the vaccine, when you talk about the drugs that is now around us, half of us are not sure what is going on. And so people like Haniki will have to play a role and educate all of us where we need to take a stand, whether it is against the government, against the company, that does not matter. I think the truth is what it matters. So Haniki, thank you very much for taking this on. I'll be at your side all the time. If you need some help, inshallah, I will, and the university will back you up. I think this is an opportunity for us to show that we are really committed to a cause of humanity, to a cause of welfare of people, justice, fairness, and all the things that we talked about, all the things that Murabbi should be enshrined in their own way of life and the way the things they do. So I hope this talk is one talk that will excite us, will make us think ahead, beyond just academic stuff. This is about real stuff. This is about life and death, as it were. So thank you very much, Haniki, for taking this on. I wish you well. Assalamualaikum warahmatullahi ta'ala wabarakatuh.
Thank you, Tan Sri, for the inspiring and cautionary, I might say, remarks. To all participants, please record your attendance with the link available in the chat room and be reminded that no recording is allowed. Without further ado, I will now hand over the session to the moderator, Tuan Haji Murshid Kassim, Dean of Center for Foundation Studies, IIUM Gambang. Please.
Thank you, and Jazakillah khairan katsira, Sister Iman, our MC for today. Bismillahirrahmanirrahim. Alhamdulillahilladzi bi ni'matihi tatimmus shalihat. Wassalatu wassalamu ala asyrafil anbiya'i wal mursalin wa ala alihi wa ashabihi ajma'in. Subhanaka la ilma lana illa ma 'allamtana innaka antal alimul hakim. Wala haula wala quwwata illa billah al-aliyyil azim. Yang berbahagia, Honorable Professor Emeritus Tan Sri Datuk Zulkifli Razak, Rector International Islamic University Malaysia, Associate Professor Dr. Lihana Burhan, Director, Office of Knowledge for Change and Advancement, Associate Deputy Directors, UMC members, Deans, Directors, our distinguished speaker, my colleagues, staff, and students, viewers on Zoom and IIUM official YouTube channel, brothers and sisters, Assalamualaikum warahmatullahi wabarakatuh, and a very good morning. First and foremost, let us be thankful to Allah Subhanahu wa Ta'ala for giving us the opportunity to be in this session virtually. And on behalf of the organizing committee, I would like to welcome all of you, Ahlan wa Sahlan, to Murabbi Nation Talk series number 5, 2021. Today, alhamdulillah, we are very fortunate, as announced earlier, to have with us Associate Professor Dr. Mohamad Haniki Nik Mohamed from Kuliah Farmasi IIUM Kuantan to talk and to share with us a topic on tackling the collisions of tobacco epidemic with COVID-19 pandemic. I believe the topic is very relevant to us in the context of the current situation. Before I pass over the session to the speaker, allow me to read briefly his CV. Associate Professor Dr. Mohamad Haniki Nik Mohamed obtained his Bachelor of Pharmacy from USM in 1992, and the Doctor of Pharmacy from the University of Tennessee, Memphis, USA in 1996. Completed a postdoctoral fellowship at the University of Tennessee before joining USM from November 1987 until October 2005. Since then, he joined IIUM, holding the head and deputy dean academic affairs post before appointed as acting deans of CFS in 2018 and the head of internalizations and global network for Kuliah of Pharmacy and Medicine in 2019. He has been actively involved in tobacco control since 2001, especially as the coordinator of the first dedicated and multidisciplinary quit smoking clinic for USM. Associate Professor Dr. Haniki is also a chief coordinator of the Certified Smoking Cessation Service Provider Program, jointly organized by the Ministry of Health Malaysia and Malaysian Pharmaceutical Society. He is also appointed by the Ministry of Health Malaysia as committee member for the Technical Working Group on Shisha and E-cigarette expert panel on e-cigarette, Health Technology Assessment Expert, Smoking Cessation, and Vice Chairman of Translating Evidence to a Tobacco Control Policy Committee. He is also being presented at multiple meetings on tobacco control, participated at various workshops on tobacco control, on tobacco the Prof unique hobby is baking. My dear brothers and sisters, before we proceed, and as a note of reminder, inshallah the time allocated for the presentation and sharing from the speaker will be up to around 11:15, approximately around 1 hour and 2 minutes, and remaining minutes, about 15 minutes, reserved for question and answer. So our audience may ask question direct to the speaker during the question and answer session later, or alternatively, you may also use the chat box to type the question which will be read and responded later. So with the introductions, the session is yours, Prof. Tafadhal mashkura.
Jazakallah khairan kathira. My dear friend Tuan Haji Murshid as the MC for today, Sister Iman, respected Tan Sri Rector, professors, associate professors, my colleagues, those who have joined today, thank you so much. Assalamualaikum warahmatullahi wabarakatuh. And very good morning. Alhamdulillah Rabbil Alamin wa salatu wa salam ala syafi'i anbiya'i wal mursalin wa ala alihi wa sahbihi ajma'in. Rabbi shrah li sadri wa yassir li amri wa hlul min lisani yafqahu qawli, amma ba'd. Okay. As Tan Sri Rector mentioned earlier today, I got to know Tan Sri Rector when he was my lecturer at USM. I was his student quite some time ago, and I think that during that time, yes, I would never imagine I would be giving a talk, a Murabbi talk, because I've always been a Murai boy. Yeah, rather than Murabbi, I'm a Murai boy. I always ask a lot of questions. I expect he would remember. I will always interrupt him because I always want to understand things. And then when I came back to Malaysia after finishing my postdoc fellowship and my PharmD in clinical pharmacy, relevant to my postdoc work, I got to see a lot of smokers at the hospitals and also around me. People were still smoking on campus back then. So I thought this is something that we need to intervene as a health professional, but more importantly as a Muslim, because I found it has to be a jihad. It has to be a fardu kifayah at that time, to because I didn't get to learn much during my pharmacy program about tackling tobacco use disorder, nicotine addiction and whatnot. So I got to learn, and then I got to share with others. So inshallah today is a bit of sharing of what little knowledge and experience I know. I'm thankful to the Ministry of Health for providing most of the slides, because I will be covering a bit on the epidemiology and impact of tobacco use disorder, and also the tobacco control strategy, smoking cessation services, particularly relevant in tackling the COVID-19 pandemic. So we need to know the problem first. Yeah, there's still a big number of smokers in Malaysia, almost 5 million. Those who are 15 years and older, based on the National Health Mobility Survey 2019. So globally, smoking in particular causes at least 8 million deaths worldwide. Okay, and in Malaysia, more than 20,000 died from tobacco-related diseases. This is a sad fact, because during my workshops, I always say to the participants that there are two ways of quitting. One, you quit before you become a statistic of this 20,000 death related to tobacco use, or the other one is that you quit before you die. So which one do you prefer? Of course, we know that ajal maut di tangan Allah Subhanahu Wa Taala, but knowing that smoking is harmful, it causes premature death and diseases. Okay, and not only there's no cost that we can put on somebody's life, but we can actually estimate what's the cost of treatment for the diseases caused by smoking, in particular cigarette smoking. It has been estimated that it actually cost about 3 billion Malaysian ringgit just to treat three major diseases due to smoking. And these are cancers, respiratory like COPD or chronic obstructive pulmonary disease, and also ischemic heart disease or cardiovascular. So just three diseases. Later, I will share with you that there are more than 20 diseases related to smoking. So it makes no sense when somebody tells you that smoking or cigarettes in particular contribute to the economy of the country, whereby if you see the cost implication results in loss of so much money, more than 200 billion productivity. Okay, the impact on health is a no-brainer. I don't think I need to dwell on that, because more and more diseases are known related to tobacco products, particularly the older ones like the cigarettes, but more and more information are trickling in from newer tobacco-related products like e-cigarettes, heated tobacco products, and so on. Yeah, these new tobacco, these new smoking products, okay, indeed alarming, and they in Malaysia there are about 1.13 million users, yeah, of e-cigarettes. So this is a big cause of concern, yeah, definitely. And this is particularly true because it's affecting our future generations, our youth, our adolescents, our teenagers. It has been reported that around 300,000 or 13.8 of our adolescents between 13 to 17 years old were currently smoking conventional cigarettes, and at least 200,000 or 9.8 were using e-cigarettes. Okay, if you look at the middle part here, this is the national prevalence, and over at least three major surveillance, yeah, prevalence studies regarding smoking, you can see here that it has not changed much. Yeah, that's the sad truth, because somebody who's addicted will be using and the addictive products such as cigarette because of the nicotine, and they will be using it, as I've said, either if they quit, alhamdulillah, but if they don't, they may suffer diseases related to smoking and die from the consequences. Okay, so the numbers shown here in percentage, you can see that from 2011 global
Dr.
adult tobacco
Haniki,
survey.
excuse me. Dr.
Yeah.
Haniki, are you sharing your screen? Seems that you...
Oh, it's not moving, is it?
Yeah. We can just see you, but not the
Oh,
graph. Oh, yeah. Thank you.
I am sharing actually.
I can see your screen.
Yeah, me too.
Yeah, maybe connection on that side good.
Okay,
You're doing okay.
Okay, thank you, Tan Sri. So, okay, let me just highlight the fact that the almost stagnant percentage of smokers in Malaysia over 10 years, 2011, 2015, and the latest is the National Health Mobility Survey 2019, 21.3%. This is still high, Developed countries have gone less than 10%, and majority of the smokers are among men, our adult men. So, Alhamdulillah that the lower percentage of smoking among women, maybe this is socio-cultural, religion, influences, but can be also under-reporting as one of the reasons. But whatever it is, we want to maintain, we want to protect our women, our sisters from becoming smokers, and hopefully they don't going to convert to using e-cigarettes or other products as well. Okay, although the percentage is lower in women, so we have to be cognizant of this fact. We want to see downward trend, of course, of prevalence among both men and women, but we know the industry is targeting women because they are sort of untapped source of future smokers. And we know there's a correlation between socioeconomic, education level, and smoking. The lower the level, the higher the smoking prevalence. And this is also true in Malaysia. A survey done, the National Survey 2019, when looked at the category or household incomes, it has been shown that the highest prevalence of smoking is among the P40. The less money people have, the more they smoke. Maybe it's related to education level, awareness, so on and so forth. Okay, and this is something alarming because during COVID-19, we know that because of lockdowns and MCOs and 123 and whatnot, we have limited resources, both individually and nationally. Okay, we talk about the adults. What about our youth? Alhamdulillah, there's a trend of reducing in percentage of prevalence among youth between 13 to 15 years old from 2003 to 2017. Okay. However, the alarming fact is that we have seen increase in smoking prevalence among our girls. Okay. And that's actually what spurred the campaign Tak Nak. For those who remember the Tak Nak campaign, early 2000, you remember, because this was a concern because of picking up of cigarette smoking among girls. But do be a bit cautious, because although we've seen that we're seeing a downward trend of smoking among our youth, remember earlier I've said that they are picking up alternative tobacco products like e-cigarettes. Okay, and if we look at the breakdown in terms of the numbers, the actual numbers, so this is where we are concerned, especially among the secondary school students, based on the kotak program, which is kesihatan oral tanpa asap tanpa rokok. So this is under dental, under dentistry of the Ministry of Health. When they go to schools, both primary and secondary schools, they were able to detect smokers, current smokers among the students. So although the number and percentage is low in the primary school, but there are many more smokers when they started secondary school. So they may have picked up around 7, 8 years old. They experimented with cigarettes, and then they became regular smokers after some time. And these are the people who then provide the numbers to adult smokers later on. Okay, because that's why if we discuss input and output, then if Salam, yes. Somebody said something? Okay, sorry. So if...
Okay, Alhamdulillah.
Tunggu
Dr. Faham dengan Dr. Azlin ya?
Please
Dr.
mute.
Mira, is it?
Your
Your mic is on. Because the voice sounds familiar. Okay. So when we talk about input and output, you need to, and the prevalence is sustained to a certain level among the adults. So meaning that this numbers are the inputs. They are providing the future smokers as adults. So definitely a huge cause of concern. Yeah, and it has been reported that the pattern of current cigarette use among Form 1 or 13 years old to Form 5, around 17 to 18 years old in Malaysia is about 1 in 10, okay, for the 22% among boys and 5% among girls. So the prevalence of smoking among girls is higher than the national prevalence of smoking among women. Yeah. So we particularly got very interested in the use of e-cigarettes among adults. We were given grants by the Ministry of Health to conduct a national prevalence study. So we found that it is indeed alarming where we have the current e-cigarette or vape user around 600,000 in 2016. And another alarming fact is that this group of dual users, 2.3% or 450,000 were using both e-cigarettes and cigarettes. Yeah, so meaning that some of them were not actually quitting their conventional or combustible cigarettes from using e-cigarettes, but they maintain using both. Yeah. And similarly, the tobacco electronic cigarettes used among Malaysian adolescents, TECMA 2016 also found 300,000, 300,000 adolescents were using e-cigarettes during that time. Yeah, and 16% around boys and 2.8% around girls. Yeah, and then 40% of them were using e-cigarettes at least once a day. Okay, so another study in 2018 done by a group from UKM found that majority of the school-based adolescents were using electronic cigarettes. So this is where we're starting to question that the reduction in the prevalence of smoking among adolescents, is it really they have stopped smoking or they just merely switching to another tobacco product such as e-cigarettes? So they're still smoking in a sense of a tobacco product, although e-cigarette is not really producing any smoke. In fact, they are producing aerosols or vapors, yeah, due to the nature of the product. But we're still concerned, yeah, particularly when we found out from the NECS, the National Electronic Cigarette Survey that we conducted, that majority of them, when they use e-cigarette, the main reason, this center part here, the main reason for using e-cigarettes at the time was just to try. Okay, so it means that they were curious. There's something gadget-like. So and then they produced, vapor that looks like coming out of a dragon. They were able to do many things, and it became a big social phenomenon, particularly over the social media. And it was alarming culturally because at the time, girls and women were less inhibited to share their use of e-cigarettes online, particularly. Yeah, so we start seeing girls promoting e-cigarettes. Yeah, and on top of that, we also got to understand a bit more the type of e-cigarettes that they use and their perception and so on and so forth. So this actually prompted the government to regulate e-cigarettes, and at the time we proposed to ban, just like any other countries, our neighboring countries like Singapore, Thailand. So they decided to ban e-cigarettes, but when we proposed it to the government, it got overturned and they wanted to regulate e-cigarettes instead. Why we are concerned and we propose to be banned? Because we understand the fact that any tobacco products, particularly cigarettes that use directly using tobacco leaves to get the nicotine, or using synthetic or extracted nicotine from the plant to make combustible tobacco products like like cigarettes, you call it manufactured cigarettes, okay, rokok putih tu, or roll your own rokok daun, or the paper-based roll your own cigarettes, and other types, including shisha or hookah or water pipes, and the heated products like e-cigarettes or other types, and also the actual use of the loose tobacco leaves, like in the form of chewing or snuffing or snoozing. So whatever form it is, we are concerned. Yeah, because we know that cigarettes, conventional cigarettes in particular, is the most sold tobacco products locally and globally. Okay. This is like water pipe has been somewhat related to the Middle Eastern culture, but with the opening of many Middle Eastern outlets in Malaysia and globally, more and more people are actually started to use water pipe or shisha as seen. Yeah. Snus is more of a Eastern European or European kind of use, but electronic cigarette and vape is particularly high in terms of interest and use in our country. It has been at one time being lauded as top user. Yeah? And of course, the manufacturer related to vape claim that they are second only to the US when it comes to the production and selling of e-liquids and vape-related products. The latest tobacco products that came to our shore is the heated tobacco products. So some of you may have seen this in various places. Now, I mentioned that our recommendation to the cabinet, to the government, was to ban, because way back, maybe 60, 70 years ago, whoever drafted the regulation and allowed cigarettes to be sold had already made the mistake. Yeah, and we are now paying the price for it. Yeah, because nicotine in cigarettes is very addictive. Nicotine, from the chemistry standpoint, is a psychoactive chemical. Yeah, so it has a stimulating effect on the central and peripheral nervous system. It also has a depressive effect on the central nervous system at higher dose. Historically, some of you may remember that nicotine was actually used as a pesticide, yeah, racun serangga. But it is dangerous. It causes, because it can be absorbed through the skin, so it causes side effects, overdose, and intoxication to those people using it. So we got better and safer insecticides, so nicotine was no longer used for this purpose. However, nicotine is still used until today in the form of either liquid or the crude tobacco leaves and manufactured into tobacco products, and it still gives the effects, the harmful effects, not necessarily because of nicotine addictiveness per se, but because the way it's delivered, which are characteristics of tobacco products. Okay, what are these characteristics? The first one, okay, it is delivered in the rapid manner. Yeah, maybe I would ask all of you to think 1 or 2 seconds. What's the purpose of cigarettes in the first place? Yeah, if I ask you what's the purpose of a smartphone or a handphone, everybody can mention this is a communication tool. Is, you know, if a pen, I would use it for writing and so on and so forth. But what's the purpose of a cigarette? Okay, from the industry point of view, it's very simple. It's just a product for them to deliver nicotine as fast and as much as possible. Okay, because these two characteristics are well studied when it comes to nicotine in causing dependence. You can see the red bars there as addiction specialists like Henningfield or Benowitz rated nicotine ability to cause dependence is higher than that of heroin or cocaine. Okay, particularly as I mentioned, in the way that cigarettes deliver nicotine. Okay, so the next question is, what makes nicotine addictive and able to cause dependence? Yeah, so there are chemicals that have been added into the products in order to preserve, to make sure nicotine is stable, it's not ionized, because nicotine is acid sensitive. So if it is in an acidic environment, it will be ionized, so it will be less absorbed effectively. So it means that this is a highly studied, researched product. Yeah, companies, tobacco companies or tobacco industries spend billions or trillions of dollars, yeah, in order to make sure that their products are able to deliver nicotine as fast and as much as possible. That's why the burning is fast. That's why there are many chemicals added to it. Okay, I mentioned to you the error of our forefathers or foremothers. I don't know who actually decided to allow the establishment of tobacco industry in Malaysia way back when. But as I've said, we are seeing the repercussions, the effects. But Alhamdulillah, to a certain extent, in the drafting of Poisons Act 1952, nicotine was put under Group C poisons, meaning that it can only be sold by licensed health professionals. Okay. However, there's a caveat. Nicotine in tobacco products are exempted until today, meaning that that's why you don't need to see a pharmacist or a physician or a dentist to get cigarettes, right? You can just buy it at any place. Although the product is harmful, it's not very common that you have a product that carries the label merokok berbahaya untuk kesihatan and so on and so forth way back when, and the product carries now pictorial health warnings or graphic health warnings, and is highly regulated. Because to my knowledge, there are only 1 or 2 countries in the world which have banned cigarettes or tobacco products, and these countries are doing it on the basis of religion. The first one is based on Islam by Brunei Darussalam. The other one is by Bhutan, yeah, because they are a Buddhist country, and because they know the effect of nicotine, that would include withdrawal. Yeah, so they cannot have their monks having nicotine withdrawal and or seeking cigarettes and smoking during the religious practice. So it is a sad truth that we also as a Muslim country, when we have the fatwa, we have the national decree that smoking is haram since 1993, but we are still not able to implement it. Yeah. So knowing the fact that nicotine is able to cause dependence, but from cigarettes there's very few intoxication potential, because a lethal dose, the dose that needed to kill an adult person has a high variability. It can be 40 milligram, it can be 80 milligram, depending on the ability of the person to metabolize nicotine. So it means that people don't necessarily die acutely from smoking cigarettes itself. You need maybe 40 sticks, 80 sticks to smoke at one go, and that's not usually feasible, right? In order to die from acute poisoning from nicotine from cigarettes. However, people can die from acute ingestion of nicotine in e-liquids. Yeah, those liquids that are sold by for purposes of using e-cigarettes. Okay. And we can understand the effect of nicotine, in particular from research done in animals, showing that nicotine interacts with certain receptors upon inhalation. It will not be metabolized because it will bypass the first pass, that has a first pass effect. It will enter the respiratory system from the smoke. It goes into the bloodstream, and it will go to the receptors to interact. It will go all over the body, but the main receptors that nicotine will interact is the alpha 4 beta 2 nicotinic acetylcholine receptors at the ventral tegmental area part of the brain. So interactions between nicotine and these receptors would cause action potential generation, and then this action potential would be passed through the reward pathway to stimulate the release of neurotransmitters at the nucleus accumbens. Okay. So there are many different types of nicotinic acetylcholine receptors in the brain, and different configuration would elicit different effects. So nicotine would interact with all these receptors, but the predominant receptors are the alpha 4 beta 2. And the release of these neurotransmitters are all the good effects that smokers will explain to you. Why I smoke? Why I smoke? Because it's pleasurable. I smoke because it makes me learn better, remember better. I can have better mood. I can relieve or reduce my stress, tension, anxiety, and so on and so forth. These are all the quote-unquote good effects of nicotine stimulation, and the responsible neurotransmitters are shown in the slides. But the main neurotransmitters or chemicals that causes pleasure is dopamine. Yeah, it's like the NTV7 of chemicals, the feel-good chemicals, dopamine. So if you get dopamine, then you feel the pleasure. So knowing these facts, yeah, the tobacco industries ensure that the nicotine delivered by their products, particularly cigarettes, would be fast-acting, and they would be able to have high nicotine plasma concentration to ensure that the release of dopamine is almost immediate. Yeah, it will take only about 10 seconds or so for the nicotine to interact with the receptors in the brain upon the inhalation. So the smoker will experience this. It's not like you smoke now and then 30 minutes later you will only feel the pleasure. So this is not how it works with cigarettes. Those who are smokers and vaping, they would know. Okay. However, nicotine is short-lived. The half-life is only 1 to 2 hours, and upon stopping of smoking or vaping or using any tobacco products, the reduction of the nicotine concentration in the plasma and also the neurotransmitters, particularly dopamine, would result in the reverse effects. If all the good effects are listed here, the reverse would be, for example, if you feel good, then you don't feel good. You feel restless, impatient, and if you initially from nicotine effect, you would have reduction in anxiety and tension, then you'll be anxious, you'll be irritable, difficulty of sleeping because before you have the arousal effect. Okay, you also have appetite suppression effect. So in reverse, the withdrawal would cause increased appetite and weight gain, and so on and so forth, including dysphoria or depressed mood. Okay, angin tak elok. So that's why people who were trying to stop smoking, we say always have some of these withdrawal symptoms for about 4 to 10 weeks. Yeah, depending. So what smokers need to understand is that this is normal. This is the effects of nicotine withdrawal, yeah, which is related to nicotine dependence. It's part and parcel of being dependent to any substance, so including nicotine. So either you wait it out, you would, for example, lawan or use your own willpower or behavior intervention, or better, you would consider using medications to reduce all these withdrawal symptoms. I wouldn't say to eliminate totally, because the way that the medications work is that they work by reducing the withdrawal symptoms, and one of the medications can actually reduce the pleasure of smoking when taken. Okay, this is just to reiterate the point that I made earlier, that in tobacco smoke is known to have about 7,000 chemicals. So the question is, how do these chemicals get into the tobacco smoke? Some of them are originally from the plants, from the process of curing. You know how they cure the tobacco leaves to concentrate the nicotine and the chemicals in it, and then the manufacturing is process itself by adding some of the chemicals. For example, if I just take one of them, I said nicotine is acid sensitive. So in the buccal or in the mouth area, when for example, after eating, the pH is usually reduced, so it's more acidic. And nicotine being acid sensitive, it will ionize, therefore it will not be absorbed buccally. But the main absorption is still through the pulmonary system. But ammonia is added because ammonia is known to increase the environment pH. So it's alkaline, so it can protect the nicotine from ionization. Okay. Similarly, if we talk about why there's methanol, for example, this is to ensure that rapid burning at high temperature. Yeah. The product that tar, like the nicotine, nitrosamine, the cancer-causing agents, which as listed here, benzopyrene, and so on and so forth, are results of burning organic materials like tobacco leaves at high temperature. Yeah, so it will produce tar. The tar is similar to the tar that you've seen to make our roads. It's just in small droplets, and over time, it would increase the risk of getting cancers, constructive, chronic obstructive pulmonary disease, emphysema, and so on and so forth. Carbon monoxide is a poisonous gas. It can kill people. People have died from carbon monoxide poisoning. We've seen those cases when people slept overnight in their car with the air conditioner running, and therefore they keep the motor running. And when there are issues or leakages of carbon monoxide into the trapped environment, people can die. Yeah, carbon monoxide reduces oxygen delivery to the cells. So you then increase the risk of stroke if there's not enough oxygen to supply to the brain, cardiovascular diseases, including myocardial infarction or heart attack, if it's less or is affecting the heart, or even to the genitals, increases risk for men, erectile dysfunction or mati pucuk. Yeah. Okay. Other than this, there are established diseases, particularly cancers. It's not just lung cancers that we talk about. Cancer can spread all over the body. Yeah, so it can metastasize. It's not just staying put at the lung area. Although the highest incidence of lung cancers, 70 to 80% of lung cancer patients are among smokers. So the 20-30% can still be in non-smokers. So there's always people saying that, oh, so and so person did not smoke but got lung cancer. Yes, we still acknowledge the fact, but this is like you're saying, okay, airline A and airline B. Airline B has a track record of crashing 70 to 80 times a year, whereas airline A maybe 20 to 30. So by right, you would not choose airline B, knowing the fact that the risk of crashing is higher. But this is the risk that smokers take on a daily basis, stick by stick basis. They don't. It has been shown that mutations, cancers, can occur with the first puff. Yeah, because there are 70 at least out of the 7,000 chemicals, at least 70 or 70 have been identified as carcinogens. Yeah, so it's not surprising that majority of smokers have cancers. They may die from stomach cancers, pancreatic cancers, but these are not often made known to the public in the sense that, oh, this is smoking related death. Yeah, rather than reported as cancer of the stomach or the pancreas. So, but if it's lung cancer, yes, people would always associate and ask whether the person is a smoker. Okay, but do be aware that there are many other chronic diseases from the top of the head to the tip of the toe, because it affects the circulation, it affects the blood vessels. Nicotine itself can cause vasoconstriction or narrowing of the blood vessels. So that fact itself contributes to increase in blood pressure, whether transient or acutely or chronically. But we know that the number one death related to tobacco in Malaysia and globally would be from cardiovascular diseases. So coronary heart disease, as I mentioned, because there's atherosclerotic process, or the process whereby the blood vessels became clogged, yeah, from smoking. It's not surprising, isn't it? You have so much chemicals that are dangerous that will start the inflammatory process. Yeah, there's what you call radical oxygen species. There are many, too many to list, harmful chemicals in tobacco smoke that contributed to all this sort of chronic diseases. Yeah, and now we have on board is the COVID-19 pandemic. I will explain that in a while. But before I go there, I just like to highlight that, remember, those 20 to 30% of non-smokers who got cancer, they may be actually secondhand smokers. They are exposed to other people smoke on a constant basis. For example, now with the MCO, people are smoking in their homes. So I hope that those listening, if you are still smoking, ensure that at least to the extent of smoking outside the homes. It's not like having your head out of the window and the rest of your body inside. It means totally out of the home. Yeah, never smoke in the car where people may still be going in after you have stopped smoking. More so if you're smoking while driving and there are children and women in the car, they will be exposed to the secondhand smoke. But there's now concern regarding third-hand smoke. Then this is when, as I mentioned earlier, when there's no smoke, there's no smoking activity seen, visibly seen, but you can smell the tobacco smoke in the environment, which are remnants or leftover from recent smoking activity. For example, in the house, you can trap these particles on the carpets, in the curtains, definitely in the clothing, yeah, so and so forth. And these chemicals would vaporize or would then be transmitted to other people, particularly vulnerable people like babies, toddlers, women, even pets. Yeah, remember that they can also be exposed to the effect of secondhand smoke. So the effect of lung cancer, coronary heart disease have been established as effect of secondhand smoke. So there's no safe level of exposure to secondhand smoke. Okay. Now I mentioned about COVID-19. So smoking has been identified as causing a higher risk for COVID-19 due to the fact that the increase in number of receptors for the coronavirus. So coronavirus, in order to enter the body, the blood system, it will be inhaled and it will go to the lungs, and it will attach itself to this receptor, the ACE2 receptors. And smokers have an overexpression. It's like having more doors, yeah? Like our government, they have front doors, they have back doors. So similarly with COVID-19, when someone is smoking and also seen with vaping, you're going to have more doors, yeah, develop on the surface of your lungs, of their lungs. So meaning that you are increasing the chance, you are making more easier for the virus to enter into the bloodstream and also the body and causing the infection. Okay. Okay. And even the Malaysian data, we collaborated with Ministry of Health looking at 5,889 COVID-19 patients who were hospitalized from the 1st of February 2020 to the 31st May 2020. And we found that the smokers actually had 2 times higher risk of getting complications on their respiratory system, kidney problems, and also liver damage. We unfortunately did not have the significant findings for death, yeah, higher death from COVID-19 among smokers. But other countries internationally, from China, from Europe, actually had published studies that showed the increase of death, increase of complications, the needing of ventilations, ICU admissions, and also overall death from COVID-19. Okay, and we are now more concerned because of electronic cigarettes, particularly in Malaysia, that became popular around 2014 or 2015, and that's historically is actually patented and like supposedly licensed for use from pharmacists, from Taiwanese pharmacists, and later developed more extensively in China. The original purpose of electronic cigarettes supposedly was to facilitate smoking cessation. Yeah, but the use, as mentioned from the NECS, National Electronic Cigarette Survey 2016 that we conducted, did not find that. Yeah, majority of the electronic cigarettes users were using it out of curiosity. They were just saying, what is this? Oh, it looks like a cigarette as a first generation. Then it looks like a longer and fatter device as a second generation. And then the third generation came in the form of mods. And then the fourth generation in the form of pods. Yeah. So all these modified open device or personalized devices for vaping, okay, had become very popular in Malaysia particularly. And other products that have been developed, especially by tobacco industries, are the heated tobacco products, as you can see in the slide on the left. They basically look like shorter or compact cigarettes, which are then put into the device, and the device would heat this tobacco rather than burning it. Okay, and then the person would inhale. It has less smoke. I've seen its use. It has less smoke compared to cigarette, but still dangerous. Yeah? Okay, so whatever classification it is, the WHO came out with a statement that all tobacco products are harmful. So majority of people would always have this question: is it less harmful than cigarettes? Of course, you're comparing something to the most evil. Yeah, because cigarette to me is the most evil products delivering nicotine for the purpose of delivering nicotine by the tobacco industry, because it comes with at least 6,999 other harmful chemicals. But anything compared to it is supposed to be harm reduction or whatever they come out with is basically still regulated in our country on the basis, as I mentioned, on the nicotine, because it's under Poisons Act. If it's not having nicotine, it's regulated under Control of Tobacco Product Regulation 2004, for example, the heated tobacco products. E-cigarettes in Malaysia, whether it's mods or the pod space, we know majority, this is even admitted by the industry, that more than 90%, and this is confirmed by our study also when we analyze the content of the e-liquid, whether they contain nicotine or not. Majority, more than 80% of the analyzed samples prove that they actually have nicotine. Similarly, the vaping industry also admitted that more than 97% of their products do contain nicotine. So that's why we were very concerned about the use and the sale of e-cigarettes. Okay, because other than nicotine, they contain propylene glycol, PG, VG, vegetable glycerin, flavors, and others. So yeah, it's not 7,000 supposedly, right? Because they claim to be safer than cigarettes. Of course, if you have less chemicals, supposedly no-brainer, you would be less harmful. However, we know that nicotine is addictive. Yeah, we know it's a psychoactive agent, so it will cause people to become dependent. But are propylene glycol and vegetable glycerin and the flavors really harmless? No. Okay, because immediate effect of propylene glycol has been shown to cause irritations on the eyes, the throat, and respiratory tract. Prolonged use can cause irritation to the respiratory tract and even cause asthma attacks. And at high temperature, when they are manipulated, they can even transform into formaldehydes, a known cancer-causing agent. Okay, they still have VOCs, or volatile organic compounds. They are ultrafine particles that still can cause inflammation and damage to the respiratory system. The formaldehyde, like as I mentioned, can still cause cancer. They even have heavy metals, especially when the way that the device is used or the type of the product of the e-cigarette device. When there's coil, the coil is from metal and they can leach into the e-liquids, or the way that people use is direct dripping, as they call it. So many things, or even dry vaping. So they can cause heavy metals to be inhaled by the user. Okay, and the flavoring, yes, we know that flavoring is actually classified as safe to be consumed as food. Yeah, we have vanilla, we have bandung, we have durian flavor, you have whatever fruity flavor, for example, for baking, for drinking, and so on and so forth. But this is meant to be ingested through the GI tract, the gastrointestinal, to go into the stomach. It's not meant to be inhaled in the form of vapor or smoke. Yeah, Allah Subhanahu wa Taala created our respiratory system is to inhale the air, get oxygen, and exhale carbon dioxide and other unwanted gases. It's not meant to be inhaling durian, lychee, apple, bandung, yeah, whatever flavor from cigarettes and also e-cigarettes. There are more than 20,000 flavors, yeah, from e-cigarettes. So all these are to entice, particularly adolescents. Yeah, they are targeted at adolescents. Okay, and they are not harmless because flavoring such as diacetyl has been shown to cause a permanent damage to the respiratory systems. Yeah, so they call popcorn lungs. Yeah, bronchiolitis obliterans. So this is irreversible, and it's particularly in the creamy type of liquid flavoring type. And in fact, it's called popcorn lungs because majority of people who work in the popcorn industry, due to the buttery, the diacetyl flavor used for the buttery taste flavor of the popcorns, develop this disease. Yeah. Okay, glycerin. Glycerin can also cause skin irritation, organ damage, particularly on prolonged use. So we talk about the flavoring agents, not harmless. The metals we all already know about its harmful effects. Yeah, the main supporter of e-cigarettes use are actually from the UK. The earlier reports from 2018 from the Public Health England is lauded and used by the vaping industry, saying that it's at least 90% less harmful than cigarettes. So it's not surprising, as I've said, based on the numbers alone. But being a relatively new phenomenon, we're talking about unknown harmful effects. Do you know that it took 30 years, 30 tahun, yeah, before the link between smoking and cancer was established? Are we willing to wait another 30 years before we get our first cancer, lung cancer, from exclusive e-cigarette user? I'm not willing to take that chance. Yeah, I don't want my future generations to curse me for not doing anything about e-cigarettes now. Okay, so this was 2018, and in 2021, this year February, they came out with another report saying that they have good evidence that vaping helps smoking cessation. Okay, so but people have rebutted, and they as usual say that this is something that's seen almost exclusively in UK. So something in the system, whether the people there have different attitude towards e-cigarette, they see e-cigarettes used as a way to quit smoking and a real harm reduction strategy, as opposed to Malaysians. Our mentality of harm reduction is different. We think that, yes, let's use e-cigarettes forever and ever. This is actually had been seen and studied and reported, because they have shown that when studies looked at the use of e-cigarettes versus, for example, medication for smoking cessation, the use of medication for people who manage to quit smoking their regular cigarette is shorter in duration as compared to people who use e-cigarettes. People who use e-cigarettes for smoking cessation tend to stay longer on the use of e-cigarettes, meaning that that's highly likely that they are dependent now from nicotine in e-cigarettes. So in the long run, they are now using e-cigarettes chronically rather than quitting any products whatsoever after they have quit smoking. And new evidence are also coming up regarding the link between e-cigarettes increasing the ACE2 receptors, as I mentioned, similar to that of smoking. So it is a risk factor for increasing COVID-19 infections, contributes to the pandemic as well. So another issue of concern with electronic cigarette or vaping is the EVALI, electronic cigarette or vape use associated lung injury. This had been reported particularly end of 2019, early 2020. In the US, people tend to add THC, or marijuana liquid, or ganja, and other drugs, and they also use vitamin E acetate to make the liquid more, how do I say, thick in viscosity. So this had been initially identified as the culprits, the chemicals THC and vitamin E acetate, but people are also seeing EVALI in users whose products, whose e-liquids did not have THC or vitamin E acetate. So the exact mechanism for EVALI is still being investigated, but knowing that vaping increases the airway inflammation, causing type 2 cytokines in the lungs of animals, can also produce lung inflammation. So we know that in COVID-19, there's a storm of cytokines, right? So when you use cigarettes or electronic cigarettes, you're still contributing to the cytokine storm. Okay, and we know that from yesterday, we had the highest number of daily cases of COVID-19 and contributes to 1 million plus overall cases of COVID-19. So this is the jihad. This is what my team and I are doing, implementing strategies for smoking cessation and vaping cessation through our services, but also through advocacy and other strategies, because we know that we need to have a good strategy and services in order to tackle this tobacco epidemic. And the tool, the reference that has been used globally is the WHO, World Health Organization's Framework Convention on Tobacco Control, or WHO FCTC. Malaysia signed and ratified this. So we are a party, a member of FCTC, and the Ministry of Health is the secretariat. Okay, so using the WHO FCTC, our control of tobacco product regulation, our strategic plans from 2015 until 2030. So all of this are put in place nicely in order to tackle the tobacco epidemic. The control of tobacco product regulation is under the Food Act 1983. The standalone Tobacco Control Act is still stuck at the AG chamber for the last 5 years. Okay, so the vision of this is to have a smoke-free or tobacco-free nation by 2040, and they target by 2025, our prevalence is 15%. If you remember, right now it's about 21.3%. So a lot of cessation to meaning people have to give up smoking, and there's a lower number of new smokers. Okay, and to reach the end game in 2045 of less than 5% prevalence. So we need to strengthen and implement the WHO FCTC on tobacco control in our country as well globally. Okay, this means that not only lower prevalence, we end the commercial sale of tobacco products. If you see in countries where strict tobacco control is practiced, for example, Thailand and Singapore, you don't have to go very far, just look at our northern and southern neighbor, they would not even sell tobacco in the same way that we do right now. The way that we do it right now, we have a power wall for tobacco industry. They put up the power wall behind the cashiers, so everybody has to go there. Although the product is haram, it's not in the non-halal section of any supermarkets or grocery stores, right, is sold openly, yeah, and clearly, and is a great advertising opportunity for the tobacco industry. Whereas in countries like Thailand and Singapore, you cannot see the tobacco products openly like that. They would put behind closed cabinets or underneath the counter. And their products are also different. Their packaging is also different. They have this plain packaging enforced, which is evidence-based, started in Australia. Um, that use the same color for all the tobacco packaging. So you cannot simply identify one brand over the other based on their distinct colors. Denormalization of smoking culture. This is the issue with e-cigarettes. They re-normalize smoking, yeah, because earlier when they came to our shore, people were saying, "Oh, I'm not smoking, I'm vaping." So it's okay for me to vape in a non-smoking area because it's not smoking, it's vaping. Yeah, there's no burning. It's only how do I say, aerosolization of vapors. So this had actually impacted the denormalization of smoking culture. Of course, there are many other strategies that have been put into place and need to be put into place to denormalize smoking further and to have zero exposure of tobacco use to children, if we were to say to really have a smoke-free, tobacco-free generation. So we hope that all Malaysian citizens born 2009 onwards will say no to smoking. Hopefully they don't even know what cigarettes are anymore. And community empowerment, this is it's definitely under the radar of IIUM. We know that when Tan Sri Rector mooted the idea of having flagships, we need to have community impact. Not to have community impact, we have to have community empowerment. Expansion of smoke-free places is one of the most effective ways to control tobacco use. For example, having strictly no smoking eating places, yeah, the one that was introduced before, or expansion of it, yeah, meaning that no smoking vehicles, private or public, no smoking homes if possible, and so on and so forth. Okay, we know the places where people usually smoke, so we try to minimize, make more public areas, public places, smoke-free areas. Okay, if we can maintain smoking prevalence among women age 15 and above less than 5%, we want to do that. And if we can achieve the end game by 2040, that's even better. Okay, so it would need community empowerment, multi-sectorial participation. Easier said than done. There's huge opposition, there's huge watering down even in the government sectors of tobacco control policies and implementation, which actually, as I've said earlier, even the standalone Tobacco Control Act has been stuck somewhere, yeah, for the last 5 years. Okay, having more public and private partnership, for example, that's why we are supporting the MQuIT program of the Ministry of Health. Okay, and the WHO FCTC, of course, with their articles, they come up with a simple acronym, Empower, so that countries can implement based on the strategies of monitoring, for example, prevalence of cigarette use, yeah, protecting non-smokers from the harmful effect of secondhand smoke. Offering help is what I focus on the most because we want to increase smoking cessation, warning about dangers of tobacco use, enforcing tobacco advertising, promotion and sponsorship ban, and raising tax. Okay. I mentioned earlier that expansion of smoke-free areas is one of the effective strategies. Another effective strategy is increasing the tax on cigarettes to ensure that they remain high and unaffordable, particularly to adolescents. Okay, so we work with the Ministry of Health. We look at the evidence on tobacco controls, and we translated that into tobacco control policy in Malaysia. Okay, And the first M is the monitoring. So we've seen that Malaysia is quite good in terms of monitoring the prevalence of smoking and electronic cigarettes use, yeah, through all various avenues, and protecting people from tobacco smoke, increasing the areas of becoming non-smoking areas. Of course, the issue of enforcement is still there, but we hope the public enforcement, meaning that we empower ourselves to do, for example, through the Islamic approach, we can intervene with our with what we say with our hands. We can write something, we can correct it, or if the lowest form of iman is at least that we would make dua in our heart for the smokers or the vapors to quit smoking. Okay, so we are rather slow, but we are doing it to the best of our abilities, with much opposition from the tobacco industry, of course, and their people who are made as their fronts, like people who are like coffee shops, associations, yeah, so and so forth. They challenged in court recently when the Ministry of Health enforce the restriction of smoking within 3 meters of any eatery places, right? So these are the things that tobacco industries do all the time globally. They interfere with implementation of any tobacco control acts. Yeah. So we hope that, as I've said, we're going to see more and more areas being designated as non-smoking areas. Okay, we now have 23 areas designated, at least, yeah, 23 areas designated as smoke-free areas. And of course, all schools and campuses, including IIUM, are designated as smoke-free areas. So by right, no smoking anywhere, but we know smoking still occurs. Celah-celah tangga, at secluded places, in the toilets, and so forth. Yeah. So which is a compoundable offense, and definitely once we have the training and the turun kuasa of our security officers, although some security officers also smoke, but we do have security officers who do not smoke, so we want to give them the authority to compound smoking on campus. Yeah, there are also smoke-free cities like Ambar, smoke-free states. Melaka has done it, Johor has done it, Penang has done it, Kelantan on the way, Terengganu, Pahang not yet, so we don't know. Maybe Selangor, Gombak is Selangor or KL. So maybe this is one of the initiatives can be taken up by IIUM to create at least a smoke-free Gombak or smoke-free you want to hold, because there are initiatives for smoke-free Kuala Lumpur, wilayah Kuala Lumpur, so you can work on that also. Okay, we hope more and more people would make their homes smoke-free, because it is in tandem with protecting the non-smokers and initiative of our neighboring countries as well. Yeah, many places have been made non-smoking areas. Okay, as I've said, this is my area of interest, offering people to help under O. Okay, Article 14. So the offering of quit smoking services from face-to-face and now to the online system. Okay, we know that Ministry of Health provided many quit smoking services in clinics and hospitals, which include these services. And we have issues, definitely, accessibility to the smoking medications. They're dependent, yeah, on the treatment because they are from the P40. They will not be able to go to the private pharmacies to buy their medication. There's also lack of involvement and lack of promotion. Okay, we know that from the 2011 National Health Survey that at least 48% of smokers made attempts to quit in the past 12 months, and 32% actually have visited healthcare providers within the public clinic and hospitals. Okay, so the MQuit program actually started in November 2015. It's the public-private partnership of the Ministry of Health, and they have reached many phases, at least 3 phases now from 2015 to 2020, and we have been along the way to support this program from the get-go. Okay, so there's getting more and more partners, more and more extensive, and we hope that this will translate to better achievement of quitting rate among smokers in our population. We have seen increasing in number of people registering for the M-Quit services, particularly due to COVID-19. Yeah, so they know that the association, the increased risk of smoking and COVID-19, so more people getting help to quit. Okay, so this has been continued with the phase 3, and we are particularly involved, myself as the coordinator of the Certified Smoking Cessation Service Provider, along with another provider, has been training health providers since the year 2003 or 4, through face-to-face workshops, and now online workshops and online materials. And we've been promoting the service and getting people to register, and also responding to the monitoring and quality audit of the Ministry of Health. Do you know that the My Sejahtera also has the Jom Quit avenue on the apps? So if you don't, this is a good way for people to register, particularly when they register for their vaccination. Because remember, even if you are a smoker and your risk of getting COVID-19 is increased, the complications from it and increase of death. So even if you get vaccination, so the risk is still there if you continue smoking or vaping. Okay, so we hope that, with this phase 3 concept, that people can register and select their own provider and the online services, or through apps or other app-based or smartphone-based services will continue. Okay, so they are upgrading, and we hope the services will be even more acceptable, accessible. We know that the B40 have issues to access. They may not have the smartphones, but we hope that they will be able to assist them. Okay. We know the public health implications. It is one of the most important cause of premature death and diseases globally and nationally. So we need to tackle this tobacco epidemic, and they are going to transform the services more and more in order to be inclusive, affordable, equitable, accessible. Okay, so I mentioned about the training. This is done with Pharmacy Society, Academy of Pharmacy, and Malaysian Pharmacy Society. So we provide this training, and I'm particularly involved in the intervention as the pharmacist for the pharmacological intervention. So we tell about the options of how to use it, and we use evidence-based guidelines. For example, do you know that Malaysia has a clinical practice guidelines on treatment of tobacco use disorders since 2016. So I was lucky to be the chairperson of the CPG, and we concentrated on both behavior and also pharmacological interventions for general smokers and also special populations. If you're interested, if you're a healthcare provider listening in, please take time to look at the report of the Surgeon General 2020, and you have more updated smoking cessation evidence-based information. As I've said, we need to tackle tobacco use dependence using both behavioral support and also pharmacological support, because these have been shown to yield the highest quit rate. You can reach 30% or more when you combine behavior and pharmacological. So which medication to use? Get to your health providers. You can register yourself to the Jom Quit, or you can talk to us at IIUM Quit Smoking Clinic Service to know which medication is most suitable for you. Yeah, Alhamdulillah, the IIUM support us to buy the medication and provide it for free. It costs maybe it's 800 to 1,200 depending on the combination of medications used for the patients. Okay, so we know that these medications work, and they have been approved by both US FDA, also in the Ministry of Health. and we have the tools to assess your level of dependence, and we'll recommend whether you need monotherapy or combination, and we have guidelines to guide which medications to be used based on your dependence. And we talked about nicotine earlier on, is particularly nicotine from tobacco products is different than the nicotine delivered by the medication, because although it's still nicotine, it is delivered in a slower and lower manner. Remember, this high delivery and rapid delivery of nicotine contribute to the dependence. But with the medication, nicotine replacement therapy, that's very low risk, less than 5%, if any, someone to become addicted to the medication. We teach you how to use it. It's over 3 months to 6 months, depending on your dependence level. We make sure that you use it properly, not like any common chewing gum. Similarly with the patch, sorry, we understand how it works, because as healthcare providers, especially pharmacists, this is our bread and butter, and we'll inform you about the possible side effects and how to reduce it. And if you're using the medication that you just swallow as a pill, we ensure that we follow you up for at least 3 months during the medication. We tell you how it works. We have the evidence behind it. It's safe even in psychiatric patients. Okay, and the common side effects and how to reduce it. Smoking or tobacco use disorder is a chronic relapsing addictive disease. We know that majority of smokers relapse. They may quit after 6 months, because that's the definition of abstinence. They quit after 6 months, but they relapse and smoke again for many, many reasons. Okay, so evidence tells us that we can further enhance smoking cessation by more intensive behavioral support and combination or intensive pharmacotherapy, meaning that from the combination, we extend the duration of treatment, for example, or we use medication that has been shown by evidence to reduce relapse. The behavioral intervention, we talk about, for example, DEAD pointers. DEAD stands for delay, escape, avoid, and distract. So we talk about how to delay smoking, how to escape yourself from triggers, how to avoid is better, prevention is better than cure. For example, situations where you know you're going to smoke, and distract, technique to distract. For example, the Ministry of Health has this 12M methods to distract yourself from smoking. So, we tell them, for example, to take wudu, make doa, read the Quran, or one of our friends in quit smoking clinic, based on evidence published, advocates the use of Fatihah and Tikakul, because during the time that you recite Fatihah and Tikakul, you already start to reduce your craving, yeah, because the craving comes every 1 to 3 minutes, and by delaying, you have this way of reducing the urge to smoke. But it will come again, and you have to recite again. So imagine a lot of pahala that you make while trying to cope with the urge to smoke. Okay. We also know that the evidence saying that the top 5 behavior change techniques would include, where is it gone? Okay. The first one is building rapport with the client or the patients, and the use of carbon monoxide monitoring as the motivational tool. This is good because we do have it at the clinic, and because of COVID, we cannot do it anymore. But when we do it face to face, we can show the patient or our client the actual level of carbon monoxide, percentage of carboxyhemoglobin in the expired air, which translates to the percentage of carboxyhemoglobin in the blood. So we know that the higher level of carbon monoxide increases the risk of carbon monoxide poisoning. Okay, how to use the medication is the counseling part, not a path rule. This is very important because people think that it's okay, I can reduce cigarettes and maintain on this number. In actuality, the benefit of quitting smoking can only be reaped fully by quitting totally. And to quit totally, remember, not a single path rule is very important, because even if you smoke a few puffs after quitting, the lapse and relapse will come very easily. because there's a nicotine hunger, nicotine monster, as people call it. It will evoke that memory cells that would trigger reinforcement of smoking again. So that's why it's a cycle. Yeah. So, and eliciting commitment to this, istiqomah is always very difficult. But through the support of having healthcare professionals, providers, and friends and colleagues, and also family would be crucial, because these are supporters for them to maintain a smoke-free life. Yeah. People always ask about cost, yeah, safety, efficacy, suitability, and cost. And I'm happy to report that all studies look at evidence regarding cost of quitting is supportive of smoking cessation as cost effective. Yeah, in fact, in the US CPG, it's mentioned that smoking cessation is a gold standard of cost effectiveness in public health. Okay, so it affirms that smoking cessation at any age, don't just think that smoking cessation would not be beneficial for somebody who's 60, 70 years old. Okay, just let them enjoy the cigarettes. That's the only thing that they have. It's not true. Quitting smoking at any age is beneficial. Okay, if it doesn't allay or delay death, it actually improves quality of life. Yeah. But again, ajal maut di tangan Allah Subhanahu Wa Taala. But if you campakkan diri ke dalam kebinasaan, you just asking for trouble. Okay. Economic evaluations focus on cost effectiveness. Intervention demonstrate that these interventions are cost effective, whether from the perspective of the user or the provider. Yeah. So there's no issue. So that's why I'm thankful to IIUM for supporting the quit smoking clinic. And we know that if you compare the medications, yeah, used, whether it's the NRT gum or the patch or combination of varenicline monotherapy, it is cheaper than the cost of buying cigarettes. Buying cigarettes alone, not considering the cost of treating any diseases that the smoker has experienced. The cost of MI is so much more, treating myocardial infarction. Even much more in the private sector if you go to the private hospital. Yeah. Of course, the tobacco industry, they have their different categories of cigarette. They say premium or value to buy or cheap cigarettes, or of course not in the list is the illicit cigarettes. But all the cigarettes, yeah, all the costs can be shown that much more just buying them at 6 months. And 6 months is the 3 months is the usual treatment of medications. So the cost is already more, regardless of the tobacco category that cigarettes are under. Yeah. So even the newer heated tobacco products, like the heated tobacco products or electronic cigarettes, they are not cheap. Yeah. They may people may think that it's cheap, but it is not. Yeah, and it's still costly, especially if you are into the lifestyle of having flamboyant types of e-cigarettes, casing and flavors, yeah, for the liquids. So what do? As a healthcare provider, we ensure that we try to incorporate the 5 A's into practice. We know that we need to identify who are the users and what type of tobacco products they're using. We don't ask anymore, are you smoking now? If you ask, are you smoking now? They will answer, no, I'm not smoking now, but later I'm a smoker. So we don't ask that kind of question. We ask, do you use tobacco? So yes or no. And then what type of tobacco? Okay, products. Okay, so and then we advise them. We try to advise with hikmah, non-judgmental, everything that Islamic perspective advocates. But as healthcare professionals, we can be direct. We can use the diseases that the patient is having, or if not, the risk of diseases that the patient may have for using such tobacco products, especially cigarettes. So by advising them, we hope then later that they would they're willing to make a quick attempt. If yes, then it's easier, then we assist them accordingly. But if not, we still want to assist them because we do not know hidayah is from Allah Subhanahu Wa Taala. They may not want to quit at the point of time they're seeing us or they're talking to you, but who knows, maybe a few minutes, a few hours later, they got news that their loved ones diagnosed with lung cancer stage 4 or COVID-19 and a heavy smoker. So it triggered them to make a quick attempt. So that's why I said if we follow the Islamic perspective of intervention of Amar Ma'ruf Nahi Munkar, so we can always make dua, although that's the lowest form of iman. But we make dua for all smokers, especially because in Malaysia, majority of smokers are Malays and they're supposedly Muslims. So we assist them to the best of our ability, and I mentioned this using behavior and pharmacological intervention. And then we arrange for follow-up because we need to see them either face-to-face or online because they need the support, as I mentioned earlier. Okay, we know that it takes time. If they have been smoking 20, 30 years, they can't expect to reap the benefit overnight. It will take many, many years, but don't fret. At least 1 year of not a single puff, their risk of heart disease is already 50% compared that to a smoker. And it will take another 14 years to the risk of heart disease similar to that someone who has never smoked. The risk of cancer, as I've said, may not be gone 100%, but it may reduce up to 50% after 10 years of quitting because the mutation, cancer, can start with the first puff. Yeah. But the earlier benefits of quitting on blood pressure, on reduction of carbon monoxide, on improvement of taste and smell, which can be a reason for the increase in appetite. So watch out, yeah. And the improvement of the respiratory function, yeah, can be seen as early as 1 month. So as I've said, there's benefits of quitting at any time point. Okay. And for medications, we advocate the use of NRT varenicline and dual therapy when needed. Okay. About e-cigarettes, as I've said, the Public Health England in particular and other supporters of e-cigarettes use for smoking cessation claim that smoking e-cigarette is effective. Okay, there is evidence. I'm not going to deny that. Much like any other treatment or intervention, there's evidence that support the effectiveness of e-cigarettes for smoking cessation. However, as I mentioned, when you compare to the use of e-cigarettes to nicotine replacement therapy or varenicline, the harmful effects of e-cigarettes is much more compared to these medications. Okay, because they are not harmless. All these e-cigarettes are not harmless. The point is, we need to use the evidence-based, the Ministry of Health, FDA approved smoking cessation medications first before we even consider the e-cigarettes. It's like the last resort, yeah? Because we know the fact that, and also been shown by studies, that the electronic cigarettes can produce or they mimic the nicotine plasma concentration as that for cigarettes. They can deliver with the development of their devices from the first generation to the fourth generation in the pods, they can deliver nicotine as faster and also in high concentration depending on the concentration of nicotine used or added in the e-liquid. So essentially, it actually delivers nicotine with the two characteristics that promote dependence. So the function is not really to help people quit smoking, but to maintain them on nicotine dependence, yeah, from e-cigarettes. So what's the point? Because we have safer products that can help people quit smoking. So why are we going to advocate such products which are unknown in terms of the long-term side effect? NRTs, varenicline, had been around much, much longer than e-cigarettes, which, as I've said, 2013, 2014 came to our country. And this, I have to show this again because I want to remind participants who may miss the effect of e-cigarettes on lung function and COVID-19. If you like to get more information, please read up the book that we co-wrote. with Professor Wee Leham from UKM on Rahsia Berhenti Merokok. I remember giving this to Tan Sri Rector one time when he visited us. Okay, so that's about O, offering help. We still have W, which is warn people about dangers of tobacco through education, communication, training, and public awareness, including the pictorial health warnings that we at IIUM was commissioned by the Ministry of Health to test out, to propose and test out. So we use pictures from the Southeast Asia region at the time to talk about smoking causing lung cancer to be a pictorial health warning. Yeah, so emphysema, all sort of cancers, oral cancers, throat cancer or neck cancer, and low birth weight or premature delivery. And this picture became the first set of pictorial health warnings for Malaysian cigarettes. So they have developed into other sets as well, and this has been evidence-based. So more campaigns had been instituted over the years, including smoke-free Ramadan, so on and so forth. Yeah. And we have been promoting this every time, especially near Ramadan, because we and all around the year, because we know the fatwa in Malaysia in 1995, as I mentioned, has already declared smoking as haram. Previously was makruh, but less evidence was available then. But by 1995, we have enough evidence. Yeah. So we know about the Islamic perspective, about the harmful effects, the mubazir, and this has actually came out in late 2010 regarding the use of blood products from pigs in cigarette butts. Why? Because they want to trap carbon monoxide that's produced in tobacco smoke. They want to reduce. They added this dried blood components into the cigarette butts. Although it is supposedly from cigarettes manufactured in European countries, but there's by no way we can be sure unless we've studied and we analyze the cigarette butts of all cigarettes sold in Malaysia. Okay, the enforcement of ban on tobacco advertising, promotion, and sponsorship is rather good. Direct advertising is no longer seen, yeah, as many years ago. But indirect advertising at point of sale, as I mentioned, still there. Okay, although despite the ban. Okay, and raising tax has always been the most effective strategy. Top two strategies to reduce smoking prevalence, as shown by the evidence globally on FCTC. But sadly, in Malaysia, the excise tax on cigarette has not been raised for the past 5 years from the cabinet tabling. Okay, the increase of tax has been shown to decrease the amount of smokers, particularly among the adolescents, because they cannot afford to buy. Okay, so I'm just going to highlight in the next 5 minutes the smoke-free flagship activities. We certify, we train our staff, particularly the health care providers, and we celebrate the World Tobacco Day. That's Tan Sri Rector with the book. We do exhibition, and Tan Sri Rector also tried the carbon monoxide. Of course, it is of a non-smoker, alhamdulillah. And we also screen our CFS students. We want to ensure that they come in, as they come into IIUM, they are non-smokers. Yeah. We hold exhibitions in many places. We run clinics face-to-face. We have 10 clients, 2 on, in pipeline. So Alhamdulillah, 3 managed to quit fully. They fully abstinent after 6 months, but some of them lapsed and relapsed due to MCO because they are at home, they're stressed, and so on and so forth. We also had sessions when we give certification. We thank you to Tan Sri Rector for supporting us all the way from the beginning. Okay, and of course to Ola, we helped in the drafting of the first IIUM tobacco-free campus policy, and the next, the implementation, as I've said, the enforcement of it, because policy without enforcement is nothing. Okay, we use evidence-based for the tobacco-free campus, and we understand challenges from the tobacco industry. Okay, even yesterday, we're still working hard to ask the government what's the status of vape with nicotine. We heard that the government has already approved the tax on the electronic cigarettes with nicotine. We know that they infiltrate all government or key government agencies, including the Ministry of Health, disguising themselves as under CSR activities, corporate social responsibility activities by sponsoring 220,000 worth of PPE through Yayasan Salam to the Ministry of Health, the current Ministry of Health. Okay, and they yesterday came out in the news or day before asking the government to regulate them, saying that they are vaping industry and they are the tobacco company. Why? Because they want to maintain people addicted to nicotine. So whether it's cigarettes, whether it's electronic cigarettes, they have their hands in it. Yeah, they are also producing e-cigarettes. So we continually go to the press. We work with Malaysian Council of Tobacco Control. We work with NGOs. We do training for our students to alert them regarding smoking cessation if they have bits and pieces of smoking cessation. So we hope to expand this more through interprofessional learning. We go online, social media, educating. We challenge governments. We ask the government. We work with other bodies, Smoke-Free Homes Malaysia. We work with other universities as well. We invite renowned experts when we don't know what to do. For example, talking about industries interference and promotion to adolescents. Yeah. And we want to keep on promoting the Jom Quit that the Ministry of Health have. We want to have more smoke-free homes, definitely. We know that recently vape issue has come out because of the child. At least two videos went viral through the social media, people showing kids below 12 years old vaping. So they were able to buy these devices. So it's a big joke saying that we can control vape when we have failed to effectively control tobacco all this while. So we know that tobacco epidemic was since COVID-19 pandemic. We need to implement evidence-based policy. We need to be more cognizant and stop the interference. And hopefully more our healthcare professionals in IIUM and all IIUM staff particularly would have the knowledge and skills to deliver the 5 A's. If you can deliver the 5 A's, do the asking and advising, yeah, because that is doable. And we need to play our roles based on the Empower strategy. So with that, I thank you so much for your attention, and I thank you to Dr. Hairul Nizam from Ministry of Health for the slides. Thank you.
Alhamdulillah, and shukran jazilan, Prof. Haniki, for your very informative, comprehensive, insightful, as well as in-depth sharing on the harmful impact and the risk of tobacco or product of tobacco. And now, of course, with new e-cigarette coming in, so have been shared just now, okay, on the campaigns, the assistance for quit smoking. So inshallah, I believe that this is part and parcel of what is referred, okay, as amal ma'ruf and nahyu munkar, inshallah. And I'm attracted to the ayat highlighted, the phrase mentioned by Prof just now, jangan kamu mencampakkan diri kamu ke dalam kebinasaan, okay, which basically refer to the ayat is taken in surah Al-Baqarah, ayat 95, wala tulqu biaidikum ila tahlukah. Do not throw yourself into destruction with your own hand, biaidikum. It is, the choice is yours. Is the person, is our own choice to smoke or not smoke. And if we are smoking, then to quit, for example, and all these principles, all these guidelines are there. So thank you very much, and I believe probably there are questions from our audience. So I'll prefer if there is a direct question from those who are the Zoom platform. If there is any, that you may post direct to Prof.
Assalamualaikum, Prof.
Yes.
Sorry.
Yeah, please.
I'm Aida from the Poison Center. I'd like to ask Prof, how do we have any data on how well is the products regulated? Because at the hospital side, we've seen a few cases of vape-related injury. Recently, we had one patient who was admitted because he lost consciousness after vaping. And after discussing and doing some quick check in HTAA as well, there were several patients who came in with several complaints of loss of consciousness, not really withdrawal symptoms, more of very alarming symptoms yang kita tak biasa tengok lah. So because the worry is that these new electronic devices can, because it's liquid, you know, we don't want unlicensed production, because you know in overseas drugs are made under the table. There are so many drugs, and as well as cigarettes. Because when this patient we asked for the product name because we wanted to know what is it that's causing it, because all this nicotine and some other products affect your nervous system directly, macam Prof Haniki cakap tadi kan. So they refused to give it to me. They refused to give the name of the product. They say the product is missing. So it's very suspicious that they are making their own concoction.
Yes,
so
it is.
How good is the regulation actually?
Regulation is there. As I've said, enforcement is questionable, because although there have been raids by the Ministry of Health along with the other agencies, they are stuck at the makmal analysis, makmal kimia kebangsaan (MKK) to analyze the nicotine content, because they have to prove it on the basis of nicotine. As I've said, under the Poisons Act 1952, they cannot be selling nicotine containing e-liquids, although we know a majority of them contain nicotine. So to analyze them, the only source that would be admissible to the court is from the National Chemical Lab. So they are stuck there because they say, oh, we don't have the reagents, we don't have the manpower, so it'll be more than 3 years. So you can pressure the government to answer this question. But what I can share with you is that there had been cases reported to the Pusat Racun Negara in Penang from 2015 to June 2021. There had been 38 cases of nicotine poisoning from e-cigarettes. And 63% of these cases were actually involving children less than 5 years old, meaning that they have ingested the liquid. So it's actually a serious issue. And although we have no deaths in Malaysia, alhamdulillah, mostly asymptomatic. And with what you said, it's very possible that the nicotine in liquid are contributing to this, because seizures and it's definitely one of the symptoms of nicotine poisoning. So if they do not able to provide you the information, then you can put as probable possible, and they may even have a vali, meaning that we need to do further investigation based on the CPG that's going to come out. So yes, they are brewing this liquid at home in the toilet without any. These are not GMP, but be careful. We are saying that we need to regulate them in order to ensure that the product are of standards. But you need to ask yourself, what is the indication of these products? As I've said, you know their purpose. If their purpose is to for smoking cessation, give us the evidence, register the product, provide the data to NPRA to register the product, just like any other medication or products for therapeutic use. That's my quick comment. Thank you, Doctor.
Thank you, Prof.
Thank you for the question and the response. Probably one more, if there is any burning question from members on the Zoom platform, yeah, Prof. Director.
Yeah, I just want to highlight also this is a difficult war, because they are always have one step ahead of us. Yeah, for example, when Haniki showed the pictorial diagrams on cigarette, some countries they have, within that they've got some sleeve, nice picture, you know. So the moment you buy, you put the sleeve over it, then you don't see the picture.
Yes.
This is how they actually go against it. There's no law to say that you cannot provide a sleeve. Smuggling, for example, these contraband products, we got evidence that they sponsor those smuggling, so that the government will say that they lose revenue, and when they lose revenue, then they will then institute back a cigarette as a legitimate product. So these people are one step ahead of us all the time. And this is where I think the concerted effort of professionals needs to come on board to educate the people that, this company, you cannot deal them with just like any other company with laws and regulation, because they have got different kind of a strategy ahead of us. I'll give you an example again. I think most of you probably would not know. If you look at a cigarette, there is this what do you call the filter, yeah. But many people do not know there are small holes around the filter, and these holes are basically meant for you to what do you call to inhale a lot more nicotine. Now, when they test this cigarette in a machine, they just put the machine over the cigarette, and then they light the cigarette, and then the machine will suck whatever it is. The holes are open, and therefore the amount of nicotine that gets registered after the experiments is really very, very minimal. But the moment you smoke your cigarette, you put your finger right over the hole and you block the hole. And when you smoke, then you drag in a lot more nicotine. And nobody knows that small holes around there until very, very much later, where they actually, put that deliberately to deceive us so that we can get into addiction. Now, my take on this is basically we need to understand that this whole industry of addiction, I'm going to use the word addiction in a very broad way, that includes cigarettes, that includes handphones, that includes fast food. All these are addictive industry that we need to understand their psychology, how they actually get you hooked on this. For example, cigarette, they know, I think Haniki probably know this, that they know that this product is addictive 50 years ago, but they didn't sort of announce it. They use what they call now, there's a book called Marketing Doubts, you market doubts, and you keep on asking whether it is addictive or not, and they use this strategy of marketing doubt, so that you're doubtful whether this product is actually dangerous or otherwise, because you're also experiencing euphoria and stuff like that. So this whole strategy of marketing doubts, putting addiction as a kind of a market, is what we need to get into. I mean, of course, individually, like what Haniki mentioned, to save people individually, we can do it. But the whole profile of how to look at this in a holistic global sense, with what I hope IIUM will do. I think in USM, we didn't do that because the data and also the strategy wasn't well informed. Now I think it is very well informed. I worry about handphones. I make a comparison, handphones and cigarettes almost the same. For example, handphones now, they say, now you can use your handphone many times, we will reduce the bill. You can call as long as you want, because there is something that will benefit you. You talk to your parents, blah, blah, blah. But behind it, actually, you are getting into an addictive sort of behavior, that now you cannot live with your handphone, just like you cannot live without a cigarette, And the data says it's basically the same thing. You cannot stop smoking after half an hour. You cannot stop looking at your handphone after 15 minutes. Because the addiction is the same thing. The same thing, and Haniki also, when you use handphone, dopamine now has been released. It's a kind of a pleasure coming out of handphone. So all these things, I think, needs to be assembled. And I hope IIUM can do this, so they have a broader pictures of what this is all about, and to tackle them in a more holistic way, apart from just doing it. My last question is, are you also working with schools? One of the successful story we have, and we've got this club Nafas Baru, that we work with the young, and they understand this early, then they can also, push this away when they are adults and they understand this better. Are you working with schools?
Yes, Ansri, thank you for the comments and the question. Yes, we understand, and we have been using the tobacco industry internal documents, for example, their own words against them. For example, in the 1960s, they already come out with statements saying that we know that nicotine is addictive. We are in the business of selling nicotine, an addictive drug. If we can sell nicotine, we can sell anything. So I make sure that I always use their own words against them, particularly to adolescents, because one of the companies even use statements like, we don't smoke the cigarettes ourselves. We reserve it to the black, the poor, the young, and the stupid. So then the adolescents especially, they feel, oh, this is how they are being targeted, and then we use the internal documents to that they know, that the company has known about the addictive effect of nicotine and their marketing strategies, so on and so forth. As far as the school, this is how we work with the school children. We go to the schools, and here in Kuantan, we sort of adopted Sekolah Menengah Kebangsaan Bukit Koh, because we identified as a rural school and it has many social problems, including smoking. So we've been going there through alongside collaboration with Tuan Kesihatan Remaja Malaysia or Malaysian Association of Adolescent Health, and we are going again virtually this 31st, and my group under the Smoke Free Campus Community Flagship will be having the workshop with both two schools now, Bukit Koh and also Samsas. We're going to have an online workshop where we don't have much lecture, but we always go towards interactive sessions. For example, we do the smoker's body. We ask them to outline a body and then fill in the effect of smoking, vaping on the body, and explain that and present. And it's like a competition among the groups, and the best groups, the top 3 groups will receive rewards. We also do a love letter, whereby they would write something to their family or friends whom they know are smokers, and they write a message for them to quit smoking based on love. It's not it's non-threatening, it's emotional based. So we work with other health professionals, and we know that this has been working. We ask them to write, for example, a message that I remember one of the students stood up and volunteered to read her message to her mother, meaning that her mother is a smoker. So she said that I want you to live long to see the day that I get married and deliver you grandchildren. So they use this emotive response, and we ask them to give the card to the actual smoker. If they don't dare to do it, for example, if it's the father who smokes and they don't have the courage, just put it on a place where the person will see it, for example, on the fridge. So we do these kind of things with school children. And we have now a mentoring system whereby we look at future champions of tobacco control among the school children who are willing to be mentored by us and the association. So yes, we know and we understand that school is a great place, and with COVID, there's a blessing that we now need not go to the school, but we can have them joining us with our workshops, inshallah.
Do you train some of these young school students to be speakers so that they listen better to their peers rather than listen to old folks like us? They speak to them and they explain.
The mentoring system is to how sort of like groom them to become tobacco control advocates, to be peer leaders, peer helpers.
Congratulations. So one more criteria for Murabbi as a non-smoker. Liana, one more criteria.
And non-vapor.
Okay. Okay, thank you. Assalamualaikum. Well done.
Prof Haniki, sorry nak tanya.
Boleh.
Nak refer to your clinic tu is boleh walk in ke? What is the process?
Because of COVID, we now only accept it online. So if you look at the Takrim Day today, you'll see the smoke-free campus flagship. The information is available.
All right. Okay. Thanks.
Thank you. You can also use my signature to refer for the Jom Quit.
Actually, we are running out of time. Anyway, hopefully with missions of the organizer, if I may entertain to make it fair, question from chat box, YouTube. One question only, and hopefully Prof will respond within less than 1 minute. From Encik Rahmat Abdul Latif, asking on possibility to invent products not based on drugs, but rather herbs to regularly impede nicotine addiction.
Okay, thank you for the question. Actually, varenicline was synthesized from a plant. So it's basically plant in origin. It's just that cytisine is the main chemical from the plant that actually grew in East European countries. So from this plant, they extracted the chemicals and now they have modified it and made it into varenicline, which is a synthetic drug. The issue with herbs is that we need to ensure the quality, the standard and the quality. So if we work possible, many herbs people also want us to study whether ketum can be used for smoking cessation. We said yes, it is possible. So we want to study, and then but in the end, the issue of standardization, the quality will come into place, and we have to go back and make sure that it follows the strict GMP criteria for quality, effectiveness, and safety. Thank you.
Okay, thank you very much, Prof. Alhamdulillah, now, brothers and sisters, we are coming to the end of the session. Once again, thank you and congratulations to all, especially Tan Sri Director, Office of KCA, the speaker, all participants, and those who have contributed directly or indirectly to the success of this event. Jazakumullah khairan katsira. And with that, aqulu qawli hadha, astaghfirullah li wa lakum. Assalamualaikum warahmatullahi wabarakatuh. And now I pass over the session to Sister MC.
Thank you, Tuan Haji Murshid.
Right, thank you, Associate Professor Dr. Mohamad Haniki and Moderator Tuan Haji Murshid, alongside other 400 participants on Zoom and YouTube. I've learned a lot from your illuminating session during the past hour and a half, almost 2 hours. May Allah grant the both of you the best of health so we can continue to gain benefit from your wisdom. With this, we've come to the end of the session. Please be informed that this session is also available via IIM official YouTube channel, and the next Murabbi Talk series will be held on 23rd August 2021, featuring Professor Datuk Dr. Muhammad Tahir bin Azhar. Yang berbahagia Datuk will be talking about how to be an effective Murabbi. Right, that's the poster. Thank you again, everyone, for joining the session. May Allah continue to provide us with His guidance and protection. We end with Tasbih Kafara and Surah Al-Asr.
Okay, Assalamualaikum, everybody. Thank you. Lovely hamper.
Thank you, everyone. Assalamualaikum.
Salam.
Participants may take your leave.
Thank you, Iman. Thank you, Brother Murshid. Thank you, Dr. Haniki, of course.
Thank you. I will start eating the fruits now.
Okay. Return je lah, kita orang teman.
Okay, Assalamualaikum.
Waalaikumsalam warahmatullahi.
Thank you as well, KCA. I received mine. I just received mine. Delivery, special delivery.
Thank you, everyone, for coming.
Thank you.
And thank you, Brother Murshid. Thank you, Dr. Haniki.
Start eating the fruits now.
Okay. Return je lah, kita orang teman.
Okay, Assalamualaikum.
Waalaikumsalam.
Thank you as well, KCA. I received mine. I just received mine. Delivery.